Good morning, everyone, and a very warm welcome to the last and the final webinar of Masterclass series on psoriasis. My name is Dr. Simi Kaul, and I'm Senior Clinical Editor at BMJ India. On behalf of BMJ, I would like to thank for signing in for today's webinar. Just to put things for the people who have joined us today, for the entire month of November, we have run psoriasis webinar series, addressing different aspects. Like, for instance, we started with the basics of psoriasis in the first week of November, followed by addressing comorbidities. Last week, we had discussed difficult to treat psoriasis. And today, our theme is what is new in psoriasis? The objective of the webinar is to update your clinical knowledge, enhance your daily practice, and improve the quality of care you give to your patients. Before we begin, few announcements to be made. We would run the sessions back to back. So we have 3 sessions, 2 with our international expert and 1 with our national subject expert, back to back, and during which you can post your questions. We'll not be addressing the questions after every session. It will be only post these 3 sessions, and we'll request you to type in your questions in the Q&A box along with your name and city. It will help us address your questions. We will try our best to address as many questions as possible to make the webinar more interactive for everyone. Please do fill the survey form, which will be shared with you after the webinar. It will help us improve your future experience and We'd now like to thank our sponsors, Novartis, for supporting this educational initiative. As I have mentioned in the beginning, today, our theme is what is new in psoriasis, and we would be discussing in detail the emerging therapeutics, concept of personalized medicine, and psoriasis in this COVID era. I'm so pleased to welcome our esteemed faculty for today, to start with Professor Matthias Augustin. He's the director at the Institute of Health Services Research in Dermatology and Nursing, Hamburg, Germany. Over to Professor Augustin.
So thank you very much. Happy to be here again. My task is to talk about and to predict emerging therapeutics for patients with psoriasis. And I just come back to a slide I already have shown, which indicates that in the current treatment of psoriasis, we have already a large number of treatment possibilities. And I took you through many of them, indicating that there's an abundance of treatment options, both for psoriasis of the skin and also for arthritis, much more than in any other disease that we have. So included with biosimilars, I indicated that at least in the European area, we have more than 30 drugs to know. Nevertheless, we will not just have the challenge to have to differentiate between these drugs, and the next time will be about choices and values of them, but also there are upcoming new drugs that will follow the line I have indicated here again of the different, let's say, generations of development in psoriasis care, and in the colors you see the first, second, third generation, but also small molecules which were upcoming like apremilast. So this is something which probably will prolong, and the question is how will this appear? Until now, if we talk about the biological drugs, there have been all developments in the 3 very well-known groups, anti-TNFs, IL-17 and IL-23 blockers. And we will surely have more of these molecules in these classes. But we will also have other principles and other mechanisms of action of some of the new drugs. And one of the key questions for the future decade is, will we more rely on the biosimilars, on what is existing because they are cheap and facilitate access to drugs, or will we rely on the innovations, on the new drugs which are developed? And probably it will be a mix. And if we now look at such a timeline of the next 10 years, it's for sure that the drugs that we have at the moment, which I depicted again in the previous slide, will be available for us. Probably the prices will lower. And we will also have 2 key events, and this is the invention of the biosimilars for ustekinumab and for secukinumab around these spots here in time, because then the patents are running out, and this will also induce probably the use for biologics, and it will also induce the claim to use biosimilars in those well-known drugs. But nevertheless, we will have a future upcoming series of further IL-17 and IL-23 antagonists with bimekizumab, mirikizumab, and sonelokimab. The three have been well described and new data presented at the EADV meeting some weeks ago, and I will show you some of these data in detail. Besides, there are upcoming small molecules, both for systemic or for topical use, so both are in development, as you may know, and also new monoclonal antibodies are in development. So this is what enriches and somehow also almost overwhelms us in the methods and in the options we have for future psoriasis treatment. So it's good to have a starting point right now in order to understand what will come up. So if we talk about the oral drugs, these are the orals which are available, the compounds. You don't have the fumaric acid esters in your country, but there's an EMA license, and we have specific use as first line or second line drug in psoriasis, and two have the license also for arthritis. These are some of the new upcoming drugs from different entities which are in the pipeline, and I will come back to them quickly. And these are the biological drugs which we have for use, and they are sorted here in classes, as you see, the 4 classes you know. Most of them having a license, and some are very close to being adopted into the market, but still don't have a label. So there's no points here for first or second label of psoriasis or psoriatic arthritis. But this is where they formally need to be placed, 2 being in the IL-17 and 1 in the IL-23 area. So if we start with what is new, and we are quite clear that it's coming into our known classes. One is the IL-17 inhibition by bimekizumab, and this drug has another profile of blockade, as you can depict it here. This is the scheme how the blockade of IL-17 is performed by secukinumab and ixekizumab, here being IL-17A inhibitors. This is what we also know, brodalumab, which we use in IL-17, a broader IL-17RA receptor blocker. And bimekizumab now is allocated here, blocking both the heterodimers and the homodimers of IL-17A and IL-17F. So this is the theory and the observed mode of action. And there have been 3 studies and the data shown at the EADV which put theory into practice. One, the VIVID study against ustekinumab. One was a dosing and withdrawal study, and one the BSURE study against adalimumab. And these are brand new data, and I took them from the late-breaking sessions at the EADV. The first, the BVIVID study, 52 weeks, phase 3, randomized controlled double-blind study, of course, against ustekinumab. And in this study presented by Professor Reich from Hamburg, the study design was a 4:1:2 randomization of bimekizumab 320 milligrams Q4 weeks against placebo in the first 16 weeks, and then against ustekinumab, depending on the dose as indicated in the label. And in the maintenance period, the patients from placebo switched to bimekizumab, followed by an extension period. The co-primary endpoints were PASI 90 and IGA 0/1, and this is already the results. On the left, you see the week 16 PASI 19 response, primary endpoint, and you see the comparison of bimekizumab 320 milligrams to ustekinumab, and you see an impressive difference, and of course a highly significant difference with the superiority of bimekizumab and a powerful response of 85%, which is quite a lot, even compared to the other IL-17 and IL-23 blockers. Correspondingly, also the IGA-01 with 84% was quite high. Now, this is the PASI 75 response. It's lower, as you may anticipate, but this is just week 4. So at week 4, already 77 patients roughly had a PASI 75 response, which was just one dosing at the time. So there's a clear indicator that we have a strong and very quick acting drug here. And finally, the week 16 PASI 100, which shows that bimekizumab in that dose was, of course, superior to ustekinumab almost 3 times. So all this was then also depicted on the 1 year database, and you see the PASI 90 response for bimekizumab here, with again a sustained superiority to ustekinumab, and they also sustained response of more than 80% in this ITT-NRI analysis. The same was observed for IGA-01, again a sustained response, highly significant superiority to ustekinumab. And finally, the PASI 100 response, and this is again very impressive that after 1 year, there's a sustained response of PASI 100 of more than 60% of the patients compared with 38 of ustekinumab. Now, of course, there was a high interest in the safety data, and this is always busy data with a lot of single numbers. I lead you through this because most of the data were clear and there were very few signals, but those which occurred are to be taken serious. There was, for example, a significantly high number of hypersensitivity reaction, which is not unexpected against placebo, but the rates were roughly the same between bimekizumab and ustekinumab. So this is something we know as dermatologists. But then there was a signal regarding fungal infection, and this mostly or largely was related to candida infections. And you can see that the rate of candida infections in bimekizumab was more than 10% compared to none in ustekinumab and none in placebo at the initial period. And on the long term, over those 52 weeks, again, there was this high signal of candida infections if compared to ustekinumab. So this is what we should keep in mind. So with curiosity, we of course followed the 2 other large studies and the results on this. This is presented by Ken Gordon, the Be Ready study. Again, 1 year randomized double-blinded placebo-controlled study with randomized withdrawal. So unlike the first study, here there was just a placebo arm at the entry phase for the first 16 weeks. Again, co-primary endpoints PASI 90 and IGA-01. There was a randomization then after 16 weeks from bimekizumab, people having probably a good response, to either an 8 weeks dosing instead of 4 weeks or placebo. And the placebo group went into the regular 320 milligrams per week scheme as was started here. And of course, there was a strong response by bimekizumab compared to placebo. This is PASI 90 at week 16, primary endpoint. And like in the previous study, again, here we saw a very high response of about 90%. The same with IGA-01. The question was what happened over time, and here you can see in the bimekizumab group the PASI 75, PASI 90, and PASI 100 responses as 4 weeks responses. Again, PASI 75 at 4 weeks after 1 dosing was 75%, PASI 90 45%, and even PASI 100 occurred in almost 20% of patients with just 1 dose after 4 weeks. And of course, placebo was almost 0 in all cases. This indicated that there is an early and then sustained response in the magnitude that I presented already. So the second objective of the study was to do a randomized withdrawal. I showed you the design on this. And after doing so, after no more dosing at week 16, you can see that there was a decline, of course, of the PASI 90 response in the withdrawal group, randomized and getting placebo. And after 1 year in total, 56 weeks, it landed up with 16%. So at the first months, there was still perceived some treatment effect, but then it got lost, and the others landed up in the same range of response as we have seen before. So again, the safety signals were what we wanted to see, and there were again some hypersensitivity reactions, but not many. And the major point was the rate of Candida infections. And again, you can see that there was a significantly elevated rate here. Also some Taenia infections, but much more Candida infections, which persisted, or also in the case of switching, appeared in the second part of the study. So, and then some liver and function analysis were positive, but at a quite low rate. So the third study, the B-SURE study, again was a randomized study with adalimumab as a control in the dose like in the label. And the bimekizumab dosing was also with 320 milligrams, but every 4 weeks. And then there was a cross to every 8 weeks at week 16 in the maintenance period. The baseline characteristics were the same, so the patients again were comparable. And here you already see the PASI 90 and the IgA1 response, PASI 90 on the left. You see the superiority at week 16 of bimekizumab also against adalimumab. And you see the same basically with the IgA01. The second point was to follow up on this again for 1 year. And here you can see on the left the PASI 90 responses, ITT-NRI analysis with the same magnitude of response in PASI 90 that we have seen in the 2 prior studies. You also see that those patients who switched from adalimumab to the bimekizumab group, they attained the same range of response quite quickly than those who were on bimekizumab at the very beginning. And obviously there was no evident difference between those having Q8 week dosing with those who had Q4 week dosing, as you can also see. And the same is true on a bit lower level with PASI 100, but see again that about 70% of the patients reached PASI 100 after 56 weeks. So this again shows that there are impressive results in the switching group and in the group getting bimekizumab, and there's little difference between Q8 and Q4 dosing regimens. In this third study, we saw the same signals regarding especially Candida infections with a rate that was almost the same range as we have seen in the pre-studies before. So if we now compare these Candida infection rates across the IL-17 pathway antagonists, it's evident that this is a particular point in bimekizumab. Again, the 3 studies here, the rates of Candida infections, and you see that they were much higher than in the pivotal studies for secukinumab, for ixekizumab, and for brodalumab. There has also been presented data for phase 2 at the ADV on a second IL-17 blocker, sonelokimab, which is a bit different because this is a novel trivalent B-specific nanobody, which comprises 2 sequence-optimized monovalent camelid nanobodies that are liganded here, as you can see, and that attach both to IL-17A and IL-17F and the heterodimer. So this is how it looks like. Again, You see the binding sites here, and you see the targets with both the monodimers and the heterodimer are liganded by this drug. And of course, this promises to be a drug which maybe is somehow powerful, and this was tested in a phase 2 study against secukinumab in red in a dose-finding scheme that you can see here with biweekly dosing for 12 weeks. So this is the induction period, and then another 12 weeks maintenance period that you can see again. And the placebo patients then got the 120 milligram normal load starting with week 13. This is the results. Already you see the IGA 0/1 responses from 0 to week 12 with sonelokimab for patients. And you can see, and I enhance this, that IGA 0/1 for the highest dosage, 120 milligrams enhanced load was the best, indicated by the arrows, with a response after week 12 for IGA 0/1 of more than 80%. And the same was true for the PASI 90 response on the left, again, different dosages, and the PASI 100 response. Now, if we see the curve for the highest dose, you can see that this is also the superior dose in PASI 90 and PASI 100 with a considerable superiority to secukinumab, especially in terms of PASI 100 at week 12 and week 24. So this is where the great difference occurs. And unlike in the bimekizumab trial, there was a signal of mild oral candidiasis in 6 patients. And so again, we need to observe this in further studies. The phase 3 study will be decisive on this. And so if we summarize these new data on sonelokimab, there is an efficacy which was consistent, durable throughout 24 weeks, and it was generally well tolerated with a safety profile similar to that of secukinumab, but some superiority at week 12 and 24, as we have just seen. Now, the third new biologic which we saw in data with a well-known profile is mirikizumab. Here you see the 3 licensed drugs, guselkumab, tildrakizumab, and risankizumab, and you see that there is 2 more, brolucizumab and mirikizumab, and the latter all being P90 blocker and the IL-23 pathway. They were investigated. So this is the design of the study, OASIS 2, a phase 3 randomized trial. You see the randomization for 1 to 2 dosing schemes of mirikizumab, secukinumab, and placebo, which was followed at week 16 with mirikizumab. And there were also in the long term a half-dose scheme tested for mirikizumab here. So now the baseline demographics and disease characteristics were the same. I don't go into detail for the sake of time, but this is the outcome. This is the PASI 90 for mirikizumab versus secukinumab and placebo in the induction period of 16 weeks. And you see that the curves are quite parallel with almost the same number of responses in both groups compared to placebo. And on the value for this PASI 90 was about 72-74%. And here you see the long-term outcome with a PASI 90 outcome after 52 weeks of about 80%, which is quite similar to that of bimekizumab. And so this response was also almost attained in the group which changed from placebo, but it's a more prolonged curve compared to what we have seen with bimekizumab. Now, this is PASI 100, induction period about 37%, maintenance period long-term for 1 year about 58% in the highest dosage group compared to secukinumab, which was 42%. So again, a drug, an IL-23 blocker, which is markedly superior to secukinumab, not in the short term, but in the long term. And again, there was interest, of course, in the safety of mirikizumab, and this was okay in terms of most events, that there were none really concerning events, some injection site reactions that were seen, but also in placebo, and no further signals in the special interest areas in this drug. So if we compare now mirikizumab in this OASIS study with the outcomes of the other IL-23 blockers, which compared to secukinumab, then we get the following picture at week 16. Both mirikizumab, but also guselkumab in blue, and in this case here, tildakizumab showed less effectiveness or similar effectiveness to secukinumab after week 16. So this is almost equal, but then after weeks 52, all IL-23 blockers were superior to secukinumab. So it's the long term which makes the difference between the IL-23 blockers and secukinumab. So this was in sort of journey into the new clinical data from drugs we know. Of course, the second question is, and I can only address this briefly, will there be new targets beyond of the well-known classes? And the answer is could be, because there are many different mechanisms that are involved in the psoriasis progression and the pathogenesis. We mostly focused on the immunological, but there are many more extracellular, but especially also intracellular. And this is the reason why there is still a very active number of clinical trials. This is the current map from clinicaltrials.gov on active or pending studies in psoriasis. You see it's more than 270 and mostly occurring in North America and Europe, but some also in Asia. And in these studies, very different molecules are addressed. So the pipeline is there. And if we look at the companies being involved in this, it's mostly those who are all also considered very innovative and have a high innovation index, which is listed here. So they, on the one hand, this axis are more innovative, and they are also more inventive, meaning that they bring things into care. And so I mark with P those which are working on drugs for psoriasis in the right upper area, those innovators and inventors. And they have provided a large number of target molecules or candidates for being tested in the clinical pipeline for psoriasis. And this slide is 2 years or 3 years old, but it nicely depicts on the left the clinical trials with the proportion of patients of studies, in clinical trials with small molecules here. And if this is zoomed out, then you can see that alone in the small molecule area, there is a large variation of anti-inflammatory drugs for psoriasis, with the largest being the JAK inhibitors and the PDE4 inhibitors, but many others like S1P1 receptor agonists, STAT3 inhibitors, and many more. So the field is there, and most are still in phase 1. Probably many will not be further researched on in phase 2 and 3, but some will make it. And so this is the list of those who made it in phase 2 and 3 recently. For example, you see the JAK inhibitors like upadacitinib, you see the celopitant NK1 receptor antagonist, which is already in phase 3, of course, with a certain focus on itch, and these drugs are now a subject of further findings. If you want to look this up, there's a nice list in www.psoriasis.org, and I don't go much into detail, but just to let you know. But also in the topic area, there is movement, and some of the JAK inhibitors, the PDE4 inhibitors, are substrate of topical developments, and some of them are now tested in phase 3. So unlike in the systemic area, where we have a lot of drugs, as we have seen in the past 15 years, these topical new drugs meet an unmet need, because there have been any inventions since the 90s with the upcoming calcipotriol drugs. Then this is the oral list again. I made the points already that they belong to very different mechanisms of action, also with vitamin D derivatives, for example. And then we have this special focus on the JAK inhibitors, which share a development, as you know, for rheumatoid disease, but also for dermatologic, for GI diseases. And within dermatology, some are developed also in other indications like atopic dermatitis, alopecia areata, and some as depicted here for psoriasis. There's no clear picture on this, but I guess that there will be more inventions and more focus on research in atopic dermatitis because there's a larger gap and lack of active drugs, whereas the field in psoriasis, as we have seen, is very competitive. But let's see. Then, of course, the question is which of the new drugs will finally be launched and will come into our use. We don't know, so this is to be left open, but I'm quite sure that with the drugs I've shown in the IL-17 and IL-23 field, we will get a completion of these two very important groups of drugs. And with these small molecules, we will broaden our possibilities at least to the topicals and maybe some orals as well. So with this, I thank you, and I'm looking forward to the next presentations.
Thank you, Professor Augustin. Thank you so much. I think you have given us a fair idea on what we have in psoriasis in future, at least till 2030. So moving on, we have our next session, which is on concept of personalized medicine. And for this, I'll request our national expert, Dr. Abhi Saraswat. He's the consultant dermatology at Industry Skin Clinic, Lucknow. He's also chairman of IADVL Task Force Against Topical Steroid Abuse for 2020 and 21. Over to Dr. Saraswat.
Thank you very much, Dr. Simi, for the kind introduction. And welcome to our audience to today's webinar on what's new in psoriasis. My job today is to talk about something that is very cutting edge, a lot being talked about in scientific circles in not just psoriasis, but across all disease domains, particularly chronic diseases, which is the concept of personalized medicine in terms of psoriasis for today's talk. So before I start the talk, I'll just give you an example of certain types of problems that we face in our practice every day. And these are just 3 patients that I've taken from my practice in the last 2 or 3 days alone that I would have loved to have some kind of personalization in my treatment, which would have helped me. So for example, this 37-year-old, otherwise totally healthy man was prescribed methotrexate 15 milligrams a week for plaque psoriasis after a full workup. Baseline workup was completely normal. Within 5 days of taking the first dose, he reported with severe oral mucositis and lesional erosions on the skin, as you can see. The liver enzymes were markedly raised, and his TLC was down. Again, this is a very distressing situation for any physician or any patient to go through. And I always wonder, could this have been foreseen and therefore prevented? Another patient that I saw a couple of days back, this lady, she's a 32-year-old housewife with psoriasis since the age of 20. Started as plaque psoriasis. As you can see on the lower back, there are still some plaques. And she started with the knees, scalp, and lumbar region. But she continues to develop sudden, violent pustular flares 4 to 5 times a year with no clear triggering factors, which is extremely upsetting to her. She continues to be on therapy. She has been on cyclosporin. She has intermittently been on anti-TNF drugs as well. But she is very, very dissatisfied, as are her physicians, with her treatment. Again, the questions before us are, can we predict when she is about to flare with some kind of blood test, or even better with a non-invasive like a urine or a breath test? Can we predict again which drug will work best to prevent or even control her disease flares, or predict them before they happen so that we can give her something that prevents these pustular flares? And a third example, this patient I saw just yesterday, a 45-year-old farmer. She presents with a very, very peculiar type of psoriasis. He has a 5-year history of persistent, scaly, itchy, erythematous plaques on the trunk and the extensors of limbs. Otherwise, the localization, the morphology is quite typical of psoriasis. I did a skin biopsy. It is also absolutely typical of psoriasis. But his lesions never develop much scaling, as you can see in this photograph, and have practically very little infiltration. So they are thin plaques with psoriasiform scaling, but quite light scaling. Now, why is this psoriasis different from the usual morphology? Does it have implications on his treatment, on his prognosis, on the comorbidities that we know that psoriasis have? Can we treat him any differently from the other patients who have the more regular morphology of psoriasis? So these 3 patients, I included them in this presentation just to give us a taste of the kind of questions that we have in our minds and the questions that we have that have been hitherto unanswered. And we would love to have the answers to these questions so that we can help our patients better, which brings us to the topic of personalized medicine. So this kind of granular personalization where we can look at the peculiarities of the disease, of the comorbidities, the peculiar conditions of each patient and try to give them a solution. That is what personalized medicine is. And as Felix Frue, who was the former Associate Director Genomics of US FDA, said, in a very succinct definition, the right dose of the right drug for the right indication for the right patient at the right time. So this just gives us a snapshot, except that the idea of personalized medicine goes beyond just therapy. It can be extended to prevention, primary prevention, primordial prevention, prenatal diagnosis, and risk prediction. So it is much, much more than just treatment. And there are a lot of other terms that have been coined over the past 4 or 5 years. So personalized medicine, like I said, is an approach to preventive care and drug therapy, which is based on an individual's genetic information, as well as other relevant information that may be relevant to that particular disease, which may not be genetic, it may be environmental or in other domains. Precision medicine is also another term that is talked about a lot these days, which refers to tailoring of medical treatment to the individual characteristics, both genetic and epigenetic, of each patient. And there's another term that has been coined, especially in the pharmaceutical industry, which is P4 medicine, which combines a lot of these things like predictive, preventive, personalized, and participatory medicine. The participatory aspect is a very exciting field, which is being fueled by biosensors, wearable devices, where patients themselves give us feedback, real-time feedback of their situation, and we can make quick decisions about the changing conditions of some dynamic disease processes. So how is it different? Just a table to clarify our thought process. In traditional medicine, for example, for the diagnosis of psoriasis, we rely on history, the physical signs and symptoms, and sometimes on histopathology, which is to say the phenotype. In personalized medicine, we would again try to be more specific. We would have sensitive and specific biomarkers on the blood and skin, etc., to identify specific endotypes, which are subgroups of a particular skin, of a particular disease, which are characterized by one single pathological pathogenesis problem. For the other aspect of this is prognostication. Right now, we rely on epidemiologic studies, various kinds of serum markers like CRP, LFT, imaging studies, etc. For example, just a few tests in psoriasis, which we use to judge the severity of the disease. Imaging is used to find out psoriatic arthritis, to find the extent of liver involvement, for example, if a patient is being given methotrexate. But in personalized medicine, we would have a lot of powerful, very specific genetic, epigenetic, and even soluble markers to help us there. And the most exciting applications of personalized medicines would be in terms of therapy, both efficacy and safety, where we've already moved from these blunderbuss type drugs like corticosteroids, antimetabolites, which have a lot of side effects, to a more precise, safer, more targeted drugs like biologics, which we already have. But we could do with a lot more precision in these drugs if we use personalized medicine as to which biologic to be given when, in what dose, to what patient, and what particular benefits they may choose to, they may hope to get out of it. So, but the problem is easily stated, but the solutions are not simple, because personalized therapy is very, very difficult to bring down to the individual patient level, especially in polygenic diseases like psoriasis, which have genetics, epigenetics, and a huge component of environmental influences, including a lot of lifestyle factors, which can affect whether a person actually gets the disease or not, how bad the disease is, how much it progresses, what comorbidities he gets. So there are multiple levels of complexity involved in assessing and trying to make judgments. And this is reflected as Professor Augustine has told us, that we know the various pathways that are now predominantly involved. For example, we know that in the skin psoriasis, the IL-23 Th17 pathway is the predominant pathway that gives us the best results, and that's the most commonly involved pathway there. In acute erythrodermic psoriasis, for example, the interferon alpha producing plasmacytoid dendritic cells are the focus of our intervention attempts. In pustular psoriasis, we know with a very narrow focus that the IL-36, IL-1 pathway is the one responsible for pustular psoriasis. But in spite of this knowledge, even apparently highly targeted treatments like biologics, and the newest biologics that you heard about in the previous presentation, produce about 50 to 60% complete clearance rates at best. Why is this? Secondary failures are common, and all of these things indicate a much more complexity and dynamic nature of the pathogenesis of the disease, which spurs us on to develop into what is personalized therapy. What do we need for this? We need biomarkers. And biomarkers are essential prerequisites for personalized therapy. So we have a lot of genomic markers. We have known that right from the past several decades, we've known the HLA markers of type 1 psoriasis, early onset psoriasis. We have known a lot of other markers as well, which predispose to the severe forms of psoriasis, which tell us a static picture of the genetic susceptibility. But then many of these patients may not develop psoriasis because there are a huge number of environmental factors and epigenetic mechanisms which have the ultimate impact on whether a patient gets it. So epigenetic, environmental, and lifestyle factors being so important, we need additional biomarkers to delineate the clinical phenotypes. And why do we want to identify specific clinical phenotypes? Because the ultimate aim is to identify what are called endotypes, which are subtypes of disease or subgroups of populations which are characterized by a shared underlying disease mechanism. So we want to identify a specific type of psoriasis which may have a few shared clinical features, a few shared serum markers, a few shared genetic markers, which then we know that this is one particular endotype and a particular type of intervention will work for it. So this requires a lot of complexity and a lot of information from the genetic, epigenetic, and environmental domains so that we can identify these subgroups and then target them with personalized therapy. So the main three types of biomarkers that are needed, and this is the generally accepted classification for personalized medicine, is diagnostic biomarkers, i.e. essentially things that answer what is it that the patient has, for precise early diagnosis and differentiation for other phenotypically similar disorders. In psoriasis, it might be eczema or PRP, or in pustular psoriasis, it might be an AGEP or other pustular disorders. Then the second category is prognostic biomarkers, i.e. things that tell us how it will behave. So for predicting disease trajectory, progression, severity, remission, complications, comorbidities, essential information which can give us the drugs or the interventions to prevent them or to treat them just in time. And of course, predictive biomarkers, what will work to identify specific individuals or types of disease more or less likely to respond to a particular treatment so that we can give the right drug the first time. So the promise, as you can see, is great. It is very attractive, and we just hope that it was there for our patients. But the prediction of disease and this is the promise, that we can predict at preconception and even embryonic stage which patients may get the disease in the future. We can give precise just-in-time treatment initiation and even treatment withdrawal for optimum disease controls. And of course, the biggest promise in terms of psoriasis is the reduction in comorbidities. So we know all the comorbidities, they've already been discussed in previous seminars. And if we can give targeted modifications, preventive modifications, lifestyle modifications, therapeutic modifications that can reduce the overall morbidity, that will be a great change and a great help to reducing the overall burden of disease of psoriasis that our patients have. Now, I'll just go into a little bit of detail about the type of genetic biomarkers that are available and are becoming available to us as the genetic technology and the ability to read our genome and to make sense of it improves by leaps and bounds. So there is the genomic level of biomarkers where we look at what particular genes and areas of the chromosome are there that are associated with the disease. Then we go on to the epigenome, which is DNA methylation, histone modification, which impacts on which particular disease, which particular genes are to be amplified in a particular cell or in a particular disease, which particular genes are to be read or to be switched on and off. And of course, then the transcriptome. So these genes, which genes are getting switched on and producing mRNA, so that proteins, maybe in this case cytokines, etc., are going to be produced. At a further downstream level, there's the proteome. So there are a lot of miRNAs or various non-coding RNAs which then inactivate or activate certain transcriptions so that certain mRNAs are produced and some certain mRNAs are not produced or repressed. So what particular proteins are being produced is the proteome. And of course, ultimately, there is the so-called metabolome, which looks at these very proteins that have already been produced. So these might be lipids, these might be antibodies, these might be any of these products of the genetic mechanisms which can be measured and quantified. And ultimately, this have to be correlated with what is called the phenome, that is the phenotype of the disease. And these, once we make these kind of correlations, we can lay down the bedrock of personalized medicine. This cartoon just shows in a little bit more detail the levels of the genomic biomarkers. So at the DNA level, like I said, is the genome. At the RNA level is the transcriptome. At protein levels is the proteome. And of course, the proteins, the ultimate products that the proteins make are sugars, nucleotides, amino acids, lipids, etc., which is the metabolome. And all these, if we identify and correlate them with particular aspects of the disease, give us personalized medicine. So just a little bit about the genomic level. We know that genome-wise association studies have identified more than 60 risk loci for psoriasis. And there is increasingly granular data that we are getting to identify specific endotypes of the disease, which if once we refine this, we spread it across different types of populations worldwide and do the kind of number crunching that is involved in analyzing the huge amounts of data generated, we can identify who will develop which disease variant, identify respondents to specific drugs, and of course, guide further targeted therapies. Epigenomics is a much more emerging area. Studies have just about started coming in the last 5 or 6 years, I think, which is the study of how DNA is modified so that which particular genes are going to be transcribed. And we already have histone deacetylase inhibitors, which are drugs that affect DNA methylation, and much more other drugs also are in the pipeline. Transcriptomics, which is the study of mRNAs, is the one that a lot of work is being going on right now. So there are a lot of mRNA profiles that are studied in lesional skin versus perilesional skin versus completely uninvolved skin in psoriasis patients. And a lot of inflammation-associated miRNAs have been identified, which are markers, very, very sensitive markers of disease flares and disease activity. And a lot of profiles of differentially expressed genes have also been studied. So they take a biopsy from a lesion and they take a biopsy from non-lesional skin and see which genes are upregulated or downregulated. And after treatment, which of these genes are silenced and which of these genes are activated, which tells us what is going on and how we can then manipulate these systems best to get the therapeutic results that we want. But unless all this information is correlated with the clinical characteristics of the disease, which is the phenotype of the disease, it doesn't help us much. So the aim is to translate this genome scale biology that I've just talked about to disease understanding and prediction. So what is needed is a detailed and deep description of the phenotypic details of the disease. And this is where we as clinicians can come in by making big databases, by entering phenotypic information of our patients into these databases. So biochemical tests, pathology reports, physical examination, family history, demographics, imaging details. And of course, we should have a precise and very standardized description of such data so that it is generalizable and comparable, for example, with a database of European patients or North American patients. so that we can develop a much more broader understanding of the disease and also understand the differences that may exist across populations. So the actions what are needed in this is to construct large-scale disease. What we can do from this data, of course, is that we can construct disease trajectories for individual patients based on the information of comorbidities. In, like, for example, an excellent example is the Danish patient registry that includes the health data of the entire population of the nation of Denmark. Of course, it would be a much more complicated issue with big countries, especially like India, but we can make a start somewhere. And of course, once this kind of clinical data is integrated with omics data, the genomics or the epigenomic data, then we can make the phenotype-genotype correlation and identify these specific disease types that we can predict that this particular patient is going to get psoriatic arthritis, this particular patient is going to get metabolic syndrome, and then we can help individual patients with preventive or therapeutic options. Another added level of complexity, and I hope I'm not boring you, because this is a very complicated thing to establish, and we've only just scratched the surface. So the microbiome studies are just coming in the past 5 or 10 years, and they show us that this is a huge area that has been hitherto unexplored, and it has a significant impact on the behavior on the causation and the clinical behavior of psoriasis. So for example, in a study, they found that there was a particular psoriatic core intestinal microbiome that was kind of predictive of patients of psoriasis. And this is, of course, amenable to modulation with antibiotics, prebiotics, probiotics. But this is a field that requires much, much more study and very powerful computing to make sense of what is happening to the microbes on our skin, in our gut, in our nose, genitals. So all these areas, the microbiome studies are just taking off, and they will give us an additional window and an additional layer of data to incorporate into our genomic data so that we can get a much clearer picture of what it is. But we all know that these genetic factors alone explain only a fraction of what we consider genetic diseases, including a disease like psoriasis. So a new term called exposome has been coined, which integrates all non-genetic factors. So all metabolites, hormones, lipids, and the microbiome, plus all the exposures from the infancy to the end of life, that is radiation, infections, contaminants, pollutants, diet, medicine, tobacco, alcohol, and of course the general life factors like socioeconomic status, education, stress, environment, climate. So if all these things can also be quantified, then that is what comprises the exposome, which is the every exposure to it an individual. And this is probably an even bigger impact on the disease than all the genetic combination, all the genetic information combined. So we'll need to add this particular data to the genetic data to develop truly personalized medicine. So now with this kind of theoretical discussion, I'll just take a few slides to tell you where we are now in this kind of work and this kind of research. So personalized medicine for monogenic dermatosis, for example, is in a fantastic place. We are developing newer and newer therapies for drugs that have a single genetic problem that can be corrected. So for example, this wonderful case that was published in Nature 2017 of a young 7-year-old boy with junctional epidermolysis bullosa who had a single mutation in the LAMP3 genes. And this team of scientists, they regenerated almost 1 square meter of synthetic epidermis with transgenic stem cells where this genetic defect was corrected, and they transplanted. And the photographs you can see, initial photograph where almost 80%, 90% skin loss is there. And 2 years after transplantation, the transplanted skin continues to regenerate without any problems, and the child leads a nearly normal life. So these kind of things are easier for monogenic dermatosis. But what happens when the complexity rises a bit more? And a good example in the context of psoriasis is generalized pustular psoriasis. So it is easier than plaque psoriasis because most of the patients who have generalized pustular psoriasis have mutations in one or more of 3 genes, so far as we know. IL-36RN mutations, CARD14 mutations, or AP1S3 mutations. And a lot of work has been done in this field. A lot of prognostic biomarkers have been found out which can reveal clinical behavior. For example, in a study from Chinese patients, it was found that most patients who had a homozygous mutation in IL-36RN developed de novo generalized pustular psoriasis, or they developed erythroderma, and many had exceptionally severe generalized pustular psoriasis. And of course, this was associated with early onset GPP. And those patients who had, on the other hand, hemizygous mutations or no mutation in this gene, they alternated with psoriasis vulgaris, but they had periodic episodes of pustular psoriasis. So this is basically, we are identifying endotypes now, which is our aim in generalized pustular psoriasis. And of course, this can then help identify predictive biomarkers to guide therapy. So studies have been done where they found that can the response of acitretin depend on what kind of mutation the patient has? It was found no. Acitretin works almost as well in patients who have the mutation in a particular gene or not. But of course, a novel monoclonal antibody has been developed. And there was a case report published in 2018 of 7 patients of generalized pustular psoriasis with a monoclonal antibody to IL-36 receptor, which dramatically improved generalized pustular psoriasis. And of course, an additional benefit of looking at these mutations has been to understand the correlation between pustular psoriasis and drug reactions like AGEP, pregnancy exacerbations, etc. And a lot of new knowledge is being gained in this field as well. But when we come to plaque psoriasis or psoriatic arthritis, the complexity exponentially increases. So unlike pustular psoriasis, we have more than 60 separate genetic loci which have been associated in different populations. And taken together, all these, like I've been saying in my previous slides, they account for only about 11 to 35% of the heritability or liability to get psoriasis. Therefore, we need combinations. It's quite clear that we need multiple biomarkers and combinations of specific biomarkers, looking at not just the genetic data, but at phenotype data, at environmental data, exposome data, so that we can truly move towards personalized medicine in psoriasis. So what has been done so far? So a lot of biomarkers have been identified in psoriasis, both soluble, tissue-associated, cell subset biomarkers, and much more are being added almost every week. A new biomarker is identified. So as far as the diagnosis aspect of psoriasis is concerned, there has been a development of a multi-component biomarkers which uses the expression of 4 different genes, IL-36G, CCL27, NOS2, and this C10 ORF99. And this had a 96.4% accuracy in discriminating psoriasis from other inflammatory disorders. And of course, there were some proteins, kynureninase, filaggrin-derived peptide, which have differentiated psoriasis from atopic dermatitis. So on the diagnostic part of psoriasis, we have quite a few good combinations of biomarkers that are being developed. Now, as far as the diagnosis of psoriasis subtypes is concerned, we have had interesting studies in which these group of scientists studied a transcriptomic study of plaque, palmoplantar, and scalp psoriasis. Sorry, this should be scalp psoriasis. And hundreds of subtypes of specific genes were found that were different. They found a lot of genes that were common, of course, because all of them are psoriasis. But they found differences in the genes in plaque versus palmoplantar versus scalp, thereby possibly giving us a lot of different targets and differential way of treating these diseases. As we all know, they don't respond all in the same way. And many of them are so-called difficult to treat psoriasis. And of course, there's a lot of development of prognostic biomarkers in psoriasis. So several predictive biomarkers have been developed, genetics, cytokines, cell subsets of the risk of development of psoriatic arthritis. A lot of them are there. And of course, there are several proposed biomarkers of skin disease severity, desmoplakin, complement C3, and a lot of them are being developed. But again, as of now, they're not very precise because a lot of other types of biomarkers also need to be developed so that we can be reasonably certain in our predictions. So as we move towards truly personalized therapy, what has already been done is there are multiple genetic markers which have been identified, which can predict the efficacy of biologics. Almost all currently used biologics that have been there in the market for more than a few years have now been associated with particular nucleotide polymorphisms that can predict whether a patient will respond to them or not. Of course, predictive markers for methotrexate and acitretin also have been identified. Of course, there are protein biomarkers for response to IL-17 biologics, which is beta-defensin 2. There are predictive urinary biomarkers for methotrexate-induced liver fibrosis. And a lot of these are probably going to take the place of liver biopsies or fibroscans, etc., as they have the promise to be much more specific and much more early in diagnosing changes before the irreversible change happens. There are multiple serum proteins that have been found to be associated with cyclosporin-induced renal injury, which, if measured in a patient regularly, can predict and we can stop therapy well in time. Trough levels, serum levels of biologics have been measured and correlated with response, which can allow us to individualize therapy, give them less doses or less frequent doses, or those who are non-responders can be given higher doses based on these levels. So these are just a few examples of what has already been done and what is being done in terms of personalizing the therapy of psoriasis. So the promise, like I said, is huge, right from the prenatal diagnosis to early and accurate diagnosis, prevention, predictive biomarkers, monitoring. With this huge knowledge base, the promise is almost limitless. But we need advances in computing. This kind of data, once it's generated, just for example, what are the layers of data needed to digitize the essence of a human being? This was done to one patient. So for one patient, if you want to store genomic data, DNA sequence alone takes 1 terabyte, epigenomic data takes another 2, transcriptome takes 0.7, microbiome data takes 3 terabytes. And if we add their environmental data as to what their behavior is, we pick it up from their social behavior, from maybe their internet behavior, from biosensors attached to their watches or to their cell phones, imaging. You can imagine the amount of data being generated just for one patient. So of course, there are issues of privacy. There are issues of data storage and sharing, homogeneity of data. How will data generated in India be collated with data generated in the US or the Europe? And it has to be the same. There have to be constant, simple, clear, precise definitions of everything so that we know we are not comparing apples to oranges. So a lot of issues need to be sorted out, but these are solvable problems. So I go back to my initial patients now. So we possibly can foresee and prevent these kind of idiosyncratic reactions. We know a lot of folate pathway polymorphism. We know a lot of genetic polymorphisms that can predict methotrexate toxicity and other drug toxicities, and cheaper and easily available tests are probably on the way in the not too distant future, which will tell us. This particular patient, we have the ways now, both genetic, epigenetic, and serum level markers where we can identify which patients are more likely to flare. What we don't have is very early markers of, which can predict flare, but probably they are coming. Different types of psoriasis, we know that we are classifying endotypes, which will give us targeted therapies. So to summarize, it is essential to understand and identify specific endotypes of psoriasis to initiate the development of personalized medicine in psoriasis. And this understanding can be achieved by an integrative multi-omics approach, where genetic and non-genetic biomarkers are integrated, which can result in the discovery of prognostic and predictive biomarkers to identify the likelihood of development of comorbidities, disease progression, and response to conventional and also targeted precision drugs that we have. And we are getting more and more in our hands every year. And of course, the future is very bright. Maybe in our lifetime itself, we will see with the use of this multi-omics approach, personalized medicine can start from the preconception stage and continue throughout life, offering precise preventive, therapeutic, and palliative solutions to all stages and manifestations of the disease. And in the not too distant future, probably patients of psoriasis will be able to monitor their skin condition using mobile apps and biosensors that perform image analysis in real time, send that information to the clinician who can assess the response to treatment and then recommend to stop, change, or continue treatment, truly enabling personalized medicine in psoriasis. Thank you very much for your attention. I hope I didn't bore you with the kind of complexity, but it can be overwhelming. Thanks a lot.
Thank you, Professor Dr. Saraswat. Thank you so much. I think it was very insightful. There were so many things, the challenges and the complexities involved in personalized treatment. Thank you so much. I'm sure there would be a lot of questions with regard to that, but we have to wait for one more session and then we'll take the questions. Thank you again, Dr. Saraswat. Now, I think our webinar would not be complete. This is the last session, but we all are going through a very different pandemic this time, and we have to discuss with regard to psoriasis in this. And for that, I'll request Professor Thachi to present and give us the insights on what is there in psoriasis and COVID-19. And for the people who are hearing him for the first time, he's the professor and director at Institute and Comprehensive Center Inflammation, Medicine University of Lübeck, Germany. He's also chairman of the Inflammatory Board at University Hospital, Lübeck, Germany. Over to Professor Thachi.
Thank you very much, Simi. Ladies and gentlemen, dear colleagues, I'm coming to something which is totally new probably to all of us, but also sharing with you our experience with the COVID-19, especially in the situation of psoriasis. These are my conflict of interest, and I'm moving to that what is very actual. Yesterday, I was looking how many patients have already been infected, 62 million. Looking how much there are in US, 13 million. And then I was looking also how is the situation in India, 9.3 million. And what I personally thought in India, I think that you are doing much better now than our country, because I see that the number of the new cases, daily cases with COVID-19 is decreasing in India compared to the other countries where we have an increase of COVID-19 infection. For example, I will take Germany. And we were fantastic in the past. In April, we have a very low number of the cases. We managed it very well, but somehow we were too relaxed. And if you are too relaxed, this is what is happening with COVID-19. Now we have such a high number of the cases, high number of the deaths, which is coming, as you can see, 3 to 4 times higher prevalence and also incidence with COVID-19 in Germany. So we have now 1 million of patients who are having cases of COVID-19. It's a lot. It's really a lot. And if you go further and you look, in the past, nobody was interested for epidemiologists or virologists. And this is the key, or let's say the top key opinion leader in virology in Germany. And he has also predicted this in the past, but nobody was believing that what you see in red, it means it's more than 100 cases per 100,000 inhabitants, showing the importance that COVID can spread very fast. Now, if you look carefully and you look how much we are in Lübeck, so where is Lübeck? Lübeck is in the north of the Germany, not far away from Matthias Augustin, so we are only 60 kilometers away. And this is the number of the cases. So you see, we are not totally red like the rest part of Germany. So we are doing a little bit better than the rest. But all these guys are becoming so very proud. This is our specialist who is a top virologist. And also the health minister. Health ministers are not usually the position that every politician would like to be, because it's not really such an attractive one. But now it's become very important. Last 6 months, he was almost every day on the TV. And this is the Robert Koch Institute director, which usually nobody knows in Germany. Suddenly, they become so prominent. COVID-19 brought something different, not only the Zoom, but also the COVID-19. And these are the cases from yesterday. As you can see, we decreased the number in our region, but it doesn't help you if the general number in all country is still very high. That means it's not the problem of the local, it is a general problem. And especially in Europe, it is more European problem. We are sometimes making also decisions which are country by country, also decisions which are probably from region to region. For example, the red is the region where I live. It's called Schleswig-Holstein. And this is the average in Germany. As you can see, in Schleswig-Holstein, we have genetically, probably the people have this social distancing. It took me approximately 1 year that I started to talk to my neighbors, and approximately 3 years that I consider them as a friend. So it takes very long in the north of the Germany. It's totally different situation, but it is something which is not bad, especially for the social distancing. Coming to that, what I'm talking about. At the beginning of the era of COVID-19, the signs and symptoms, you see this is published in New England Journal of Medicine. Are you missing something? Look carefully. Systemic disorder, fever, cough, fatigue. I think every child would know this. Acute cardiac injury, in every school, they will tell you what is happening. Hypoxemia, this was known to almost everyone. That they might have diarrhea, it's also known in one of the symptoms. And if that the patient are having also a lot of other problems, for example, rhinorrhea, sneezing, sore throat, or whatever, pneumonia, a lot of people heard about this. Are you missing anything? Look carefully. What about the skin? Nobody was mentioning that the skin could be interesting or important. What should dermatologists look like? What should dermatologists do in the COVID era? Are dermatology patients at an increased risk for developing the infection because of disease with epidermal barrier interruption, for example, like atopic dermatitis or also psoriasis? And I will focus today more on psoriasis, but before I come there, what are the skin manifestations emerging as the coronavirus pandemic? And can COVID-19 skin manifestation cloud the diagnosis? Probably. And what are skin problems related to the protective equipment? We are advising all our patients use antiseptics, antivirals, wash your hands half an hour, probably, if you can do it. But all of this is coming on with one question. What are the skin manifestations emerging in the corona pandemic? Are you aware of that? Have you seen this one? I will help you. There's so diversity of the skin diseases and skin manifestations that can occur in COVID-19. It is really something totally different that we have seen. We have seen some lupus-like Pernio, lupus-like chilblain lupus. We have seen maculopapular, vesicular, urticarial, or livedo-racemosa-like. So in generally, at the beginning, we were very confused. We didn't know what should we do now. Is this something relevant? Then we were looking for that. Dermatology and the skin was not on the focus because the main complication of COVID-19 was a shock, acute infection, acute cardiac injury. This was something more than focus. So everybody thought skin is not important. Dermatologists were not involved much in the treatment and management of COVID-19. And at the beginning, we had also good understanding that probably COVID-19 also is associated with vasculitis. And due to the vasculitis, this was also the way how we were able to explain chilblain lupus-like changes in the skin of our patient. And also some of this vasculitis-like diseases like Kawasaki syndrome, we thought at the beginning, it's nothing. It's similar like that what we are seeing in our daily practice, but the patient didn't have a chance to go to the physician, therefore they look different. Today, we know, no, they don't look different. It's look like that the virus is changing also some of the diseases, and one of them, it is the Kawasaki syndrome. But let me do systematically. If you see 5 different occurrence of the disease, the skin manifestation in COVID-19, what do you think? Which one will they have a more severe course of the disease? Can we predict as a dermatologist? Probably yes. On the very left, you see chilblain lupus-like. Then you have the macular one, or vesicular one. Then you have urticarial one, maculopapular one, and one is just like an livedo racemosa, which sometimes can have also necrosis. And the question was, at the beginning, everybody thought that the patient who are having this chilblain lupus-like, these are the highest risk. And let me show you the data published in British Journal from 375 patients who had also skin symptoms. And it was very nice done. If you go and look, the chilblain lupus or pseudo-chilblain lupus-like disease occurred in the patient with COVID-19, the probability that the patient survive is 100%. And at the very early beginning, personally, I thought also, this is the highest risk group because they have also some more immunological processes, having more vasculitis. But it was not true. If you look to the vesicular one, patient survival, 100%. Urticarial, I thought urticarial, these are the patients who are having more type 2 inflammation, having probably also higher risk reacting with the lung, having the cytokine storm, but this was also not the case. 100% of the patient survived. And if you look at this maculopapulosis, 98, and the highest risk occurred in the population who were having livedo or even necrosis, because the probability to survive was a 90% or 10% probability of dying on the COVID-19, and skin was the best biomarker in predicting from the beginning which course the disease may go. So if somebody is having pseudochilblain changes or vesicular or urticarial, these are the good predictor. If somebody is having maculopapular, it's still good but not excellent, and livedo and necrosis, these are the patient from the beginning with probably a most severe course of the disease. And if you go further and you look also what kind of drug these patients are taking, it is interesting that the use of the systemic treatment is increased with livedo and necrosis, and it lasts in the patient with pseudochilblain. So today we know pseudochilblain is self-limiting. You don't need a lot of treatment, but in case of livedo and necrosis, be very cautious. Interesting was also to look the age. The pseudochilblain occurred in young patients. The vesicular, 45, urticarial, more older, maculopapular, in average 55, and livedo and necrosis more than 63. Somehow interesting. Age correlates fantastically with the skin manifestation in the COVID-19. And this is something for me also interesting that I have learned, that also risk with pneumonia and hospital administration is probably lower, but is not excluded. Also, patients with vesicular and urticarial can be admitted to the hospital. And you see percentage from 13 to 44 to 86. So if you see somebody with a skin changes and they are going toward the COVID-19, you know from the beginning, pseudochilblain probability to be hospitalized is only 10%. And if you have livedo, skin changes, probability of hospitalization is 86%. I think this is something of the particular important, how a dermatologist can predict a course of the disease. But I don't think that the stage 1, the early infection, is an issue. As dermatologists, we are probably aware, as immunologists, allergologists, that there are 3 different stages of the acute respiratory distress syndrome. The first stage, it's early infection. Patients with psoriasis usually have a not really a higher risk on a viral infection. And due to that, probability of getting COVID-19 disease is lower compared to the normal population. The second stage, this is a stage where you have the pulmonary phase. The patient are having abnormal chest imaging. They have an increase of liver enzymes. They are having low or normal procalcitonin. But what we see, this is there where the disease is becoming more on a lung. And then that what is the most risky one, this is the third part. And the third part is the hyperinflammation phase, where we have a cardiac failure. We have all the signs and symptoms of the COVID-19 severity disease that we have experienced in a lot of cases in the last few 6 months. Let's go to that, what is happening in the COVID-19. We know that the virus SARS-CoV-2 is binding to the ICE receptor, and it's binding in lung epithelium and also the gut epithelium. So therefore, you have also the 2 symptoms, which are very typical. You have the cough, for example, or also diarrhea. And then the attraction of the different cells is very typical. You have neutrophils, but also the T cells. And the T cells are very crucial for the viral clearance. And as you see, for example, that the viral clearance, this depends more on interferon gamma, presence of IL-12, 21, but also interferon. But you know, in patients with psoriasis, viral clearance was never a problem, even with the biologics that we are using every day. The biggest issue was this part, hyperinflammation. In the hyperinflammation, we have an increase of TNF, increase of IL-17, increase of IL-6. So everything which inhibits the production of these cytokines in this dangerous phase of hyperinflammation could be beneficial. So in fact, we have learned that different classes of the drugs may have a different effects on the different microorganism. For example, in a viral, none of them is having a higher risk, not a TNF, 70s or 23 in psoriasis. The bacterial one, okay, at the beginning, we're very reluctant to introduce a patient to a TNF inhibitors because we thought that they will have a higher risk on pneumonia, which was probably not the truth because we have learned from our colleagues from rheumatology that TNF patients even were doing better. The fungal is not playing an important role in the COVID-19 era. And then we are learning to have a well-functioning polymononuclear cells, neutrophils. There is a TNF important. But you see that 17 and 23 is not very crucial. So we are learning that probably you might have a higher risk of infection with viral diseases and vectors and microorganisms at the beginning, but later on, it doesn't look that this could be an issue in patients with psoriasis. So we are learning, and there are two main questions that should we address. Patient with psoriasis should be advised to follow the measures. I think this is very important, but not to have more fear than for example, the normal patient who are not having psoriasis. And how can we help them? Should they have an seasonal inactivated influenza vaccine? Yes, they should do it. And of course, they have to do also the mass protection. But if you do too much mass protection, it can happen that they may have a Koebner phenomena. This is, for example, a picture which was just recently also presented and also published. And I like it very much because I didn't have this kind of the Koebner phenomena due to mask-induced psoriasis lesion as a Koebner phenomena. So imagine if you see something, could be also it is COVID-19 mask-induced disease or Koebner phenomena. The American Academy has just recently issued a very recent guidelines, also more on psoriasis. How are the effects of psoriatic disease itself on the COVID-19 illness? So psoriasis, patients with psoriasis appear to have a similar rate. So they have been very defensive. My personal experience is they have a lower incidence on a COVID-19 infection. The severity is driven by different risk factors, so I agree, and also comorbidity. So it's not the same if you have a patient who is young, has no comorbidity, compared to a patient with a severe psoriasis, having a lot of comorbidity, especially if he has diabetes, obesity, and even a cardiovascular diseases. This other patient, like in a normal population, with a higher risk. So we cannot generalize. We should take also other risk factors. And I think that a lot of patients may have comorbidities, and this may increase the mortality. I was just looking to one of the studies presented and published, how are the patients who are treated, for example, with IL-17. And so that a lot of these patients are having comorbidity like hypertension, myocardial infarction in the past. A lot of them, 1/3 of the patients are having a high BMI. So I think this is probably a high risk of that, what we are learning in our daily practice. I was looking also to the National Registry of Patients with Inflammatory Rheumatology infection. So I think this is interesting one because this was the first one published. And rheumatologists are also reporting COVID-19 cases, and they have also shown that 60% of this patient have been recovered, 30% have been hospitalized, and some of them also with intensive care unit. But what it comes, how many of patients died? How is the mortality? And mortality, I was looking carefully, it was mainly patients with rheumatoid arthritis and also psoriatic arthritis. And not all of them have been age of 70, 80. Some of them have been 50 or 60. And what is crucial, the anti-rheumatic treatment, glucocorticosteroids, sulfasalazine, steroids. Wherever you look, there are steroids and also comorbidity. That what is really leading to the higher mortality is the addition of the systemic steroids in the treatment of psoriatic arthritis and also rheumatic arthritis. So if you have a chance, if you would like to advise your physician, if you would like to tell them what is the highest risk, is probably higher risk. Of course, there are comorbidities, but the highest risk at all is the use of the systemic steroids, methylprednisolone. I'm not talking about dexamethasone, methylprednisolone in our daily practice. And if they have interrupted the treatment, yes, they interrupted the treatment. But the problem is that it is not think about the half-life. The effect of the systemic steroids, they last for years. And the American Academy has just recently also issued the guidelines, how should we manage, how the patient with psoriasis and psoriatic arthritis can manage the disease in general. And I think it is important that we learn that, for example, even cyclosporin, which is the most broadly immunosuppressive, was not found to alter the risk of the COVID-19 in 130 patients in Italy. Interesting, in rheumatology, they shown also the TNF inhibitor do not really impact the COVID-19 infection and also the curse. Furthermore, the patient who have been on TNF, they had an even better outcome during the latest stage, so it was somehow beneficial. And at the beginning of the year of COVID-19, so we thought, okay, we should probably avoid the new patient to introduce them TNF inhibitors. Today are probably different. We think that it is not a risk. And together with rheumatologists and also gastroenterologists, we think that TNF can be also even initiated in a patient if they don't have an active infection and if the patient are not having a contact with somebody who might have a risk of COVID-19, or they are in a risky region where you have a hotspot, to be called as a hotspot. I think that we have to consider that some of these patients will say, come on, this is too risky for me. I don't want to receive anything. I don't want any systemic treatment, so I will stop the treatment. It might happen. And if it happens, then the disease will aggravate. And sometimes the question is the disease itself also not bearing us also a lot of other risky factors, for example, impact on physical, emotional health, and also disease itself is having also short time, but also in a long-term implication on the patient. So we have to consider treatment of patient with psoriasis is something that I will always suggest. Especially if you are having, and we are going to the RETSN guideline, the British guidelines regarding the biologic, for example, this is that what the vast majority of you probably have interest to know how I'm going to manage if I have somebody on a biologic. And we were talking together with our colleagues from rheumatology, and we treat together our patient. And once we are treating the patient together in the COVID era, so we work together with our GPs and also other rheumatologists and also dermatologists. So they send us the pictures, and together with our rheumatology, this is the head of the department of rheumatology. So we are looking also to the hands, looking, do we have a need for adjustment of the treatment? Do we have a need for more aggressive treatment? Looking how the joints, because the joints, you cannot somehow improve the joints or restore that what was destroyed during the inflammation. Joints, once they are destroyed, we have no opportunity to repair. Therefore, it's very important to stop the development of radiographic progression in the patient. And this is the way how we usually to go together. And we are looking, okay, do we see any difference compared to that, how it is in the past? Can we adjust the treatment? Or it's mandatory in some patient that they restart the treatment because the patient had fear of the treatment. And together with rheumatologists and also gastroenterologists, we see the patient. And some of these patients at the beginning of the era had fear to come to us, but it was very important to have a contact with them, to call them, the video conferences. But, in the diseases like, for example, psoriatic arthritis, you need also to press. You need to see, is it inflamed? Is it swollen? It's tender, where it's tender. and look carefully how the treatment is also improving or even aggravating the disease. So this was a very important offering to this patient and a very good feeling that they are under control and we are there to support them. So this was very crucial for all of us. I know that it's not easy to work in a hospital today and even in a private practice or a patient clinic. The patient are coming, they have to do 1,000 things. They are not able to come in if they don't have an appointment. You don't have emergencies. They have to call it in advance. A lot of these patients, if they have any symptoms or have somebody in the family or in their friend environment that might have a COVID-19, this patient are excluded from the visits. But what is important is that we keep them together and looking carefully for their symptoms. Also, again, I will recommend this article, which was just recently published in December. It will be published in a few days. And it was shown what should patients with psoriatic disease do if they become, let's say, infected with the COVID-19. What was advised that they have to adhere with evidence-based COVID-19 therapies, nothing experimental. Don't start anything which is not recommended by infectious disease specialists and the task force for the COVID-19. What we have learned, and this was also the most recent one, that supportive treatment care for a mild disease, for example, systemic steroids and remdesivir, could be a treatment which will be in need for this patient, and there are no contraindication in the cases that the patient become positive to get this treatment. What we suggest, once the patient are suspicious or the patient are suspected to have a COVID-19, or they have a symptoms of COVID-19, or they have positive COVID-19 by themselves or somebody in family, they should interrupt the treatment. And approximately 10 to 40 days after the negative test, they are able to restart the treatment again. And I think this is very important that we keep the close contact to the patient, tell them what to do, and this should be interdisciplinary approach among rheumatologists, dermatologists, and specialists for infectious disease. It's necessary. And what is important that you also know, and I know that you are aware, that chloroquine and hydroxychloroquine are not recommended for the prevention of the treatment. What we have seen, a lot of the patients with psoriasis thought, come on, at the beginning, let's take some chloroquine. It was even not able to buy it anymore. And this may also provoke psoriasis. Psoriasis may aggravate while the patient are taking hydroxychloroquine or chloroquine. Italy and also Spain have a lot of experience, and we are looking also toward of these countries, especially in the first wave of the COVID-19. What we have seen that, okay, there was no big difference between the different classes who are getting the disease, and the study population, you see it was 1,830 patients, and the good news was the mortality rate was low, or it was zero, better to say, compared to the general population. So the patient on psoriasis had a very low mortality. The hospitalization rate was also lower compared to that what was happening in the normal population. And also, if you see the incidence rate was not much higher from a general population. This was reassuring that independently, if the patient have comorbidity, like obesity, cardiovascular diseases, or diabetes, or they have been on different drugs. For example, the vast majority of them have been on TNF inhibitor, IL-17 inhibitor, or IL-12/23. None of these patients had a severe disease or died on the severity of the COVID-19. So this is something very reassuring that we are on the right way regarding our patient with psoriasis. I know you shouldn't look at this one, it's terrible, but I like this one to show you among all the drugs that they were, let's say, brought together with a severe COVID-19 course. It was interesting, only one patient died, and this patient was on apremilast. But again, it was not apremilast itself. If the patient have other diseases, especially malignancies, these are the patients of the highest risk. Not only, let's say, the comorbidity, but also malignancies, present malignancies they may have a cause. It's not always the drug. It's probably not only the comorbidity, but also malignancies are leading toward of this risky situation. Just recently in October at the Blue Journal, it was also published an experience, and I think this is also important to have own experience, how our own experience with the different drugs. And with TNF inhibitor, this is only 400 patients, but it's very realistic because among these 400 patients, it was shown how many of them have been positive. It was only, you see the 5 patients have been positive, and among of them, 2 of them have been on TNF. None of the patients who have been on IL-17 or 23 become positive. Only one with IL-12, 23. But it is not fair because the number of the patient, as you can see, differs. However, one in IL-12 and one and 2 in TNF inhibitor group. In methotrexate, it was the same number like in IL-12, 23, and none of the patient who had IL-4 receptor alpha, dupilumab, or other immunosuppressive become. So the rate finally was very low, and none of the patients have a severe reaction or had experienced anything which was not in line of that what was published until now. So it was really reassuring, even in the countries like in US where we have a high risk patient, even this patient, nothing occurred. Personally, I like this scheme very much. What is, let's say, suggested, what can be more risky, and how can I proceed once I'm making a decision, which treatment should I initiate or keep the patient? So that's what you see on red. This is the highest risk, high dosage of steroids. So avoid steroids. Among the biologic, probably anti-CD20s or rituximab. I know that you have a lot of patients with pemphigus and you are treating them occasionally also with this drug, but be careful. This is one of the biologic considered to be not red, not green, so somewhere in the between. And regarding immunosuppressive like cyclosporin or mycophenolate mofetil, they are somehow more green. So it means, okay, can be used. It is not a higher risk, but they are not extremely safe. Then we have anakinra like IL-1 receptor alpha in rheumatology, then TNFs, then 12, 23, and 23s and 17s. And finally, apremilast and methotrexate. They are in a very similar way with the best results, which are also expected for anti-IL-14, 4 and IL-13, and also anti-IgE, showing this range of the different drugs that we are using from very red to also green. Green will be the best one. I know that you will ask me a question, and I will start from the beginning to answer them. What should we do? If we have somebody who is on methotrexate, cyclosporin, or whatever, should we continue? Should we switch or should we stop? No, you shall continue. Don't switch and don't stop. Should I combine with something else? Avoid combination, especially avoid the combination with steroids. This is something which is increasing the risk. What should I do with biologic? Should I continue? Yes. Should I taper it down? If it's necessary, if it's a need and the patient is doing well, you can do it. Any consideration for disease activity or certain disease? Not at all. Should we start for newly diagnosed patient? Yes, but you have to ask the patient where they're coming, do they have experience, if somebody's having an infection in the family, is he on the risk, etc. When to stop and how long? Don't stop. You can continue. It's not an issue, but if the patient are having a risk or an environment which are exposed to the risk, then you should consider this special situation. I think there is no clear yes or no answer. Coming to the last part of my talk, and to that what is also coming every day, we are discovering something new. In November 9th, it was a new drug, bamlanivimab, which is approved for as emerging use authorization in US, and something also new. Also to that, what we know, all of us, remdesivir, we have heard. And at the beginning, it was a lot of contradiction, should be used or not. And I personally love the NIH treatment guideline sign because it's updated very frequently. So if you want to learn more about the COVID-19 treatment guidelines, go there. And you will find the panel recommendation, which I find is very nice. It's showing to you that basically you have two drugs which are recommended. It's remdesivir and also dexamethasone. Depends in which patient. In the red one, patients who are hospitalized and required invasive mechanical ventilation or ECMO, dexamethasone, and also plus dexamethasone and remdesivir. So even if you don't have the opportunity to have remdesivir, then dexamethasone is a treatment of choice in this patient, but not methylprednisolone. So I think these are two differences which are very important, very crucial. And then we had a discussion with Simi before we started the meeting about the vaccine. Is vaccine coming? And you see that it was on Friday, November 20, so 1 week ago, Pfizer and BioNTech submit authorization request to the FDA. So we are expecting to have a positive information. And I don't know if you know, but BioNTech is from Germany. It's a small company. They invented and they have done the first successful vaccine where the protection is hoped to be 95%. So something at least in a hope on that. And I think what is interesting, it was also the update. FDA authorized the first COVID-19 test for self-testing at home. This is also coming. And this was from the 17th of November. So I will try to do it as actual as it is. I know that a lot of things I was not able to mention, but it's important to keep distance. And if you are in Lübeck, for example, looks very nice, but do you see any person outside? Not a lot. This was the beach during the first lockdown, the first wave. Nobody was in the beach near to Lübeck. And then what happens in the summertime? We were so happy. Finally, the weather was good. We were enjoying the summer and the distance was there. What happens if the people are coming from other cities? For example, the neighbors of Professor Matthias Augustin, they're coming to Lübeck. And then what happens? What happens. We are talking about social distancing. We are wondering about the contact, and then we are wondering why the numbers are going high. This was the German summer. So we paid in autumn, as usual. So with this, I would like to thank you very much for your attention and very happy to accept your questions.
Thank you, Professor Thachi. Thank you so much. I think we are now open for question, and I'll request all our participants to please post our question. And from here, I'll request Dr. Abir Saraswat to take it over, and we'll start the discussion with our subject experts. Over to Dr. Saraswat.
Yeah, thank you, Dr. Simi, and thank you, Professor Thachi and Professor Augustin, for your fantastic deliberations. We have a few questions from our audience. There is a question on the role of tofacitinib in psoriasis from Dr. Tripathi in Patna. And let me give you the context for this, because just last week, yeah, I hope you know. Just a couple of Indian companies have just come out with very cheap
generic
copies of tofacitinib, and it is probably going to explode as far as prescriptions in India are concerned. And therefore, you have questions on your experience, specifically in psoriasis, I believe, because it's already approved for psoriatic arthritis, and not many dermatologists may be treating that. So your experience and your pearls of wisdom about tofacitinib use in psoriasis. Professor Thachi or Professor Augustin, whoever wants to go first.
I think we can both share our background on this, and in fact, we participated in one of the clinical trial phase 3 studies of tofacitinib, and there has not been the attempt to get this license finally for psoriasis of the skin. And we rarely use it in arthritis because there are many more options that we consider more valuable and more evidence-based with more data that we have. So I can basically do without it, and have very few patients who are on tofa with arthritis, but none with psoriasis of the skin. And of course, this needs to be also balanced with the health care environment. And I wouldn't want to comment on what happens in India, and I don't have enough facts on this. But Professor Thachi probably also has an opinion on this. Please.
Yeah. Once I was in India, I saw that in Bangladesh was the first country offering the first tofacitinib. And we were discussing about psoriatic arthritis, and they asked me about tofacitinib. Can we combine it? I told them, come on, how can you do it? Tofacitinib is very expensive. The EMEA, so the EMA, the European agency, did not approve it mainly because of the price. It was nothing about not efficacy. It is an effective treatment option. But it was the benefit and risk, and they got more toward the risk. So tofacitinib is a very effective drug. You have two different dosages. You have a dosage of 5 milligram and 10 milligram. 5 milligram is good rheumatologic dosage, but not good for the skin. For the skin, you need 10. The second risk is that in Asia, especially in Japan, but you are not a Japanese, they have a risk of herpes zoster. And the second problem, what are negligated in India, is that tofacitinib and JAK inhibitors in general are having a higher risk also in the TB. So you have to do the same issue like you are doing with the other biologic. It's no doubt if you give a high dosage, twice daily, 10 milligram, it's extremely effective. It's like etanercept. It's not the effect of let's say, of the high dosages, but it's a very extremely effective, and probably among all the oral that you have, this is the most effective oral treatment for psoriasis and psoriatic arthritis. And the price that you are having, 30 euro, for a month. So we are talking about the cost, which are on the level of methotrexate, if not cheaper than methotrexate. So this makes it totally different. And probably also that's what will happen in the future with all the JAKs. So my personal view is, yes, it's effective, but be careful. It has a lot of the side effects. You need experience to manage the side effects. If you screen the patient very well, you have a good chance. But careful, tofacitinib is one of the drugs that, in my personal experience, I have never experienced more side effects than with tofacitinib.
Okay, that's helpful. That should give a clear signal to Indian dermatologists, because as you know, financial considerations are very important in our country, because most of the people are paying out of pocket, and a cheap drug often becomes a very heavily prescribed drug just for that reason. And with this drug, as both of you have said, there are several caveats, especially in our country with a high TB burden and overall infectious disease propensity because of various reasons being high. We have to be very careful. I guess this would be the message. Yeah. Anything else? Yeah.
Yeah, maybe I can add also, I haven't gone into the depth of the safety issue, but there have been several black box warning and red hand letters to the doctor, not just about infectious risk, but as you know, about thromboembolism and cardiovascular events. And there has been a recommendation by the German Board of Physicians to not use it in patients elder than 65. So okay. This is also a recommendation, and this also provides a warning. So I think in any age group, we should be very careful and at least inform very well about the risks.
Right.
But this will not stop in India, the use of tofacitinib. This will not stop. I know this one. And this patient are looking desperately for this. But in the case of COVID-19, if any drug is having a risk, the JAK inhibitors are having a high risk. This isn't a pan-JAK. This is not something selective. This is not also something which would selectively inhibit only one JAK. This is inhibiting many JAKs. And this may have an increased risk in the COVID-19. So if you can wait a few months, will probably not be bad in the patient where you have to do it. Select the one they can get it and not having a higher risk.
Correct. I think that's a pretty comprehensive discussion on its role. I hope Indian physicians will use it responsibly. There's another question from Dr. Tushar Parikh from Ahmedabad about the variation of drug effect according to climate change, particularly secukinumab. I think he means whether he may have noticed, probably from what I understand from this question, does it work better in summer, or are there differences according to the season as to the response to secukinumab or biologics? I think that's the question.
But I think this is quite an important point in some geographical areas, because we know that there's much less disease burden in the northern hemisphere, at least in Europe, in summer than in winter, and we have seasonal effects. So this should really be controlled in clinical trials if they are not enrolling all year long, but normally this happens. And if it comes to the treatment planning, we have a subgroup of patients that where we know that they have very little disease in summer and high disease in winter, and they may be candidates for not continuous treatment if they don't have other comorbidity. So we just send them to the beaches of Lübeck, as you have just seen, that they recover from the skin there, unless they are not let in by the Lübeck people who want to have empty beaches.
No, we don't go. You know, in the summertime, we don't go on the beaches because there are people from Berlin and also from Hamburg, you know, so we have to
Stay away.
Stay away. But I mean, to answer your question,
Yes.
there are TNFs and also IL-17. The 17s have a risk of the candida. And you know
Yes.
that in your country, you have a higher risk of generally candida and also the mycosis. So if they are in a wet region where it's not only warm but also wet, the risk of the candida might be higher. But generally, the psoriasis having a benefit, but the risk of candida will be higher. So be careful, especially if you have candida in the region. This may aggravate the disease. So I think if you have a dry climate, it's fine. So,
Yes.
but it is not if it's dry and humid.
Exactly. Which brings me to an important question. When Professor Augustin was presenting his data on bimekizumab and the newer IL-17s, and he also mentioned the high incidence of mycosis. And I don't know whether you are aware or not, in India, we are going through a horrible epidemic of dermatophytosis, of resistant tinea caused by a new subtype of T. mentagrophytes for the past 7 or 8 years. Really bad epidemic going on. So I was worrying, I was even looking at the tinea rates that you showed in your table, not just the candida. And I think that may be a bigger concern for us if these new IL-17 inhibitors come into our country.
Well, this is really true, and I haven't shown the data more in detail, but there was an elevated signal also for tinea, not just for candida. And I mean, this study population was well protected, was well controlled, and so the risk in the real-world care may be much higher given the situation in India. So if it comes to the use of bimekizumab, which is still far ahead of us, then we should be very careful and check also how to manage this. And as you have seen also in the other IL-17 blockers, the tinea rates were not zero, but there were some. And so this requires a good preventive program if we treat patients. And the details is something you know better than we if it comes to the resistance rate.
I think the patient with psoriasis are lucky that their skin is, the cells are dividing very fast. So the mycosis is slower than the skin. So once you stop the treatment, they have no problems of mycosis because it's impairing very fast. I think with 17, we have a specific candida activity. We see also mycosis, but this is not a big issue. This will be an issue more in the JAK inhibitors. Because with JAK inhibitors, you will see not only bacterial, but also mycosis more, because it's general suppression. I think with 17s, I agree with Matthias, you will have an increase probably of the candida, but it's manageable. Candida is not so resistant like Triophyton-metagrophytes that you are having at the moment in your country. Don't bring it with us, otherwise we have also a problem.
No, we are sending samples to your country. There are helpful mycologists in your country, like Professor Pietro Nenoff, that we are collaborating with and working. They're very, very helpful. And they are the ones, in fact, who identified this new strain that we have.
Finally, they are happy that something happened to them. You know, last 15 years, nothing happened.
Yes, I think they're getting a lot of interesting work to do, and we are providing the material.
Of course.
Okay, there is another question from Dr. Anup Kumar Tiwari. This is specifically to Dr. Thachi. If any biologicals cannot be given to a COVID-19 positive psoriatic patient, I believe studies showing lack of evidence of increased risk of severe COVID-19 due to the same biologicals must have significant confounding factors. So I guess he's asking about your opinion of whether you've said that if there are any biologicals that cannot be given to COVID-19 patients.
So let me give you, let's say, a view of, it's my view and also a view from the recommendation. The view of recommendation is, if you have somebody who is in a biologic, whatever biologic, TNF, 17, 23, 12, 23, the risk is not higher than in a normal population. So this is positive. What is also positive that if you look on the skin and also in the blood, if the patient are taking continuous dosages of the biologics, the risk of infection is lower than in a general population. The risk is mainly higher of infection in the first 3 to 6 months. And so therefore, if you have to introduce, we are a little bit reluctant in a patient with comorbidity, if they have a risk to get infection. So these are the only cases where I'm a little bit more cautious, but it doesn't mean that I will not introduce. At the beginning in Germany, Matthias knows this, we were discussing, should we recommend TNF or not? So we were a little bit reluctant to recommend introduction of TNF at the beginning. But now we have revised our own opinion. We are also human. We don't know everything. And once we see as everything fine, so we revised our opinion. So even TNF inhibitors can be introduced in the COVID-19 era. But the most important is be careful, especially in the patient who are having a higher risk. We don't see that it will be in a higher risk, but the combination with steroids, this is that what rheumatologists in your country and also in our country are doing frequently. GPs are doing this also because, you cannot come to dermatologists. It's more expensive, or you have to wait longer in India. You go to GPs and get the steroids. So I think this will be my message. Keep them away of steroid.
Systemic steroids. Yeah, exactly. There is a question on biomarkers. Can we predict psoriasis by particular markers before it develops? So what is the current state of the art? I know I've presented a lot of theory. I'm not personally involved in any work on this. So where are we in terms of predicting who actually gets psoriasis? Any firm leads? What are the timelines? Can you perhaps look into the looking glass and tell us maybe 5 years, 10 years down the line, we are going to have something like that?
Actually, it's challenging to look into the glass because we don't know how strong and how really the predictive value will be. You have given an excellent presentation on this, Dr. Saraswat. I liked it a lot. And
Thank you.
But you left this open how a time frame could be. And if we talk about non-lesional persons who are just there and maybe have a family history of psoriasis, and then we still are not able to predict strongly enough with robust predictive value if they get it or not. I think that there's maybe some risk factors, but not a stringent way of prediction. But I'm curious to hear your and also Diaman Tachi's opinion on this.
Yeah. Professor Tachi first, yeah.
We are working on this, and we call this precision medicine inflammation. We get in a huge grant because, if you don't have a grant, you mentioned everything is expensive, and everything goes in these resources. So personally, I think, yes, we can predict, but we have a problem. We don't know the biomarker. If we will know the biomarker, then we can predict. So we are working, all of us, we are working toward of that. How can we predict the disease? At the moment, everything is going toward of microbiome. As you have mentioned, for example, there's some lessons learned from gastroenterology. Gastroenterologists are looking a lot on the gut because they think, and they are right, that the stimulation of our immune system is coming through the contact with the environment. And it is not everything about suppressing. So I think in the future, from this knowledge, we'll have more stimulation of our immune system and less immunosuppression. So this is something positive that I am learning. But as somebody who is living in Germany, I am not really with my mind. I don't like this transplantation of the stool. This is from the idea. Whatever you do, I don't think I can leave this to gastroenterologists, but I will not do it in dermatology. I think it's important that it is also risky. Don't do it, because you make transplant also a lot of things that you don't want or you don't know. So microbiome, at least in my personal opinion, will be one of the important. The immunophenotypization is something that we are now recently doing. So what do? We take the blood from the patient before we start any treatment, and we are looking in the blood which kind of the cytokines are exposed at the beginning before we start the treatment. And then we are following this patient and looking how the, as you mentioned, endotypes, how the phenotype and how the immunophenotype come together with genetic background, and you are doing endotypes. Who can do it without such a support of the money? So we need 70 million. 70 million, it's a lot of money for this. So we are far away of the standardization of this one. So I think the future will be in precision medicine, but in research. In the daily practice, it will take years until we'll get I hope before I go and retire that we have a chance. And then once I'm retired, then everything is fine.
Okay, yeah, nice. Thanks for that. Yes, I believe the problem with biomarkers is that currently we're looking at only the genetic and epigenetic aspects of it. And psoriasis has such a huge environmental and non-genetic impact on who gets it, how bad it is. So that's the biggest challenge, how to integrate that information with the genetic information and the information of cytokines, etc. that we have. And of course, I appreciate your answers, and I understand how difficult it is to prognosticate. Even countries like Germany are worried about finances. We know how really difficult and how expensive this kind of research can be. Thanks very much for that answer. Are there any more questions, Dr. Simi? I don't see any. And how are we for time?
Simi, you are mute.
We have exceeded our time. I think just quick some concluding remarks, I think from all the subject experts, and then I'll officially close the webinar. Dr. Abhi Saraswat, from you have helped us a lot with the, it was a very insightful session. So if take-home messages we have to give to our participants, what it will be?
I think from my side, I would like to thank the participants for attending on this Sunday morning. And I hope they got some good points from Professor Thachi's and Professor Augustine's talk, and got some interesting science fiction-like stuff from my talk, I guess, and some hope for the future. Professor Thachi has been specifically pointing out the positive things that we have to look forward to in terms of psoriasis therapy, and we are thankful to him for that. And also the caveats that we mentioned about the new drug, especially tofacitinib. I think we are all very excited in India with this new drug, but you've heard what both of the experts have had to say about this drug, and I'm sure we'll all be very careful in using this drug, and the new biologics also that are coming to India. And I hope that we'll be able to help a lot of patients with these new drugs. Thank you very much. And after that, I would like to invite Professor Thachi for his remarks.
First, Professor Augustine.
Thank you. I appreciate your kindness. Thank you. I enjoyed all talks, especially, of course, yours. And if I should conclude and have an umbrella view on this, then it's for sure that we are in a privileged situation to have so much to offer our patients with psoriasis. And this plethora of treatment options is something we need to structure and to put into an evidence-based order. And I think the P4 medicine, or the P-personalized medicine that you were talking about, Dr. Saraswat, is the best chance. We have to not be precise in terms of having the best decision at the single patient, but also think in a more comprehensive way, think about the costs and everything. So I think this is the path we need to go. And I took out from the, again, very excellent presentation of Dr. Thachi that we have a immense and a very exciting speed of new knowledge and insights in Corona, which we didn't know 1 year before, actually. And so I'm really excited about the speed of new insights and the research which is done worldwide in your country and ours. And if it comes to treatment of psoriasis, it's for sure that we need to inform our patients a lot, because they are scared. They read bad things in the newspapers or internet, and we need to put this into a clear message to them, and the message is clear, and this means that they shouldn't be concerned having psoriasis, having systemic treatments. We know the risks, and we can surely help them better if they stay on drug. And so that this would be my conclusion from your presentations.
Thank you. Dr. Thachi.
Thank you very much. So I would like to close also the session. We had 4 very nice session. I don't know what we are going to do, Matthias, next Sunday at 6 o'clock in the morning.
I wake up.
Now we will have a problem on Sundays, but there was a wonderful 4 weekends with you, 4 Sundays, sharing with your experience, learning from you, and also exchanging our experience with you from the pathophysiology, epidemiology, new treatment option today, precision medicine, real life patient, comorbidities, and also finally that what is preoccupying us also in COVID-19. But this will not be possible without the support of BMG. Simi and Poya, you have done a lot of job, a lot of people also in behind. It was not so easy, especially not easy to catch Matthias August and me at the same time, at the same place. It's also a big issue. But I would like to congratulate you, and I would like to thank you also a bit for today's chairperson and sharing everything fantastically, and to our colleagues who have chaired in the last 3-4 weeks everything so perfectly. So I would like to thank you very much, and I hope we have a chance and opportunity to see each other again in India or in Germany.
Thank you so much, Professor Thachi. I think I'd like to take this opportunity not only to thank Dr. Abir Saraswat, but also our, subject experts like Dr. Paras Ramani, Dr. Murlidhar, Dr. Sunil Dogra, for making it more relevant to our participants. Because, as a subject expert, they have a lot of insights to it. And when they add to it, I think the session becomes much more interesting. And I think we'll not be able to complete without thanking our participants, as everyone has said. Thank you so much for investing our time on Sunday. I sincerely hope that we have met your academic expectation. If you have any questions, any queries, any concern, please feel free to write to us. We'll try our best to address these questions. And this brings us to the end of this webinar series. As Professor Thachi has mentioned, it's been 4 weeks, and this is the last. And we'll wait to hear your feedback, suggestions to improvise us. Till then, stay safe, take care of yourself and your loved ones. And it's BMJ India team signing off. Have a wonderful day. Thank you so much.
Thank you.
Thank you.